We are recording, so I'll get started here. Neither me nor my mentor, Lisa, have any financial conflicts of interest to disclose. As far as off-label uses of medications, given that COVID-19 is a newer disease overall, several medications are being utilized that are currently being used as emergency use authorization or not authorized at all, as evidenced in dexamethasone. And we'll talk about these in the latter third of the presentation, but this is a comprehensive list of the ones that we'll talk about today. And we'll get into the learning objectives here. So we have 3 for pharmacists. Describe how the pathophysiology of COVID-19 can impact the cardiovascular system. Differentiate cardiovascular manifestations of COVID-19 and analyze the cardiovascular impact of medication used for COVID-19. For technicians today, we also have 3 learning objectives. First one being distinguish between typical COVID-19 symptoms and those that are potentially cardiovascular related. Let's see, okay, sorry. Solid chat, nothing to worry about. Next one here, list potential cardiac related diagnoses that could be secondary to a COVID-19 infection. And finally, identify medications used to treat COVID-19 that may impact the cardiovascular system. In order to accomplish those learning objectives, we have an outline here. First off, we'll talk about SARS-CoV-2, the pathophysiology and how it impacts cardiovascular health. And then we'll dive into cardiovascular complications of COVID-19, specifically highlighting myocarditis, heart failure, arrhythmia, and acute coronary syndrome. And finally, as mentioned previously, the last kind of third of the presentation, we'll talk about the impact of medications used to treat COVID-19 and the cardiovascular impact specifically. So without further ado, we'll jump into the introduction pathophysiology. SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, causes the disease of coronavirus disease 2019, or what we commonly refer to as COVID-19. Typically, it manifests as a respiratory illness, commonly a cough, shortness of breath. Congestion can also present with a fever and muscle pain or myalgia. There can also be cardiovascular abnormalities that can be quite common, including myocarditis, or what we commonly might know as a heart attack, heart failure, arrhythmia, myocardial infarction, stroke, deep venous thrombosis, and pulmonary embolism, amongst other abnormalities as well. And I should have said myocarditis, not myocardial infarction. Sorry about that. The incidence of COVID-19 and the mortality associated with it, by the end of 2020, 1/3 of the United States had been infected. I think we were all very familiar with that, but it's an important thing to note that was before vaccines were introduced. So vaccines were introduced right about the beginning of 2021. So even before then, 1/3 of the United States has been infected. And since then, there's obviously been much more infections. And worldwide, as of last month, February 2022, there had been 400 million cases of COVID-19 in the world and over 5.8 million deaths worldwide, which just obviously highlights the deep impact that it has in the community. Beyond just death, it does have other burdens, such as cardiovascular disease, which can be quite prevalent in COVID-19. Anywhere from 7 to 17% of patients might experience a myocardial injury during their infection, and that's typically evidenced by laboratory markers, imaging studies, and symptoms associated with COVID-19. So this has a profound impact in many ways, and also impacts the cardiovascular system, which is the purpose of this presentation, and we'll dive into it a little bit more. As far as SARS-CoV-2 virology, it is a single-stranded RNA virus. It's depicted here in this image. The virus itself binds to the angiotensin converting enzyme 2 receptor through a spike glycoprotein. And the spike glycoprotein is evidenced here by this clover shape, which surrounds the outside of the virus and pairs onto the ACE2 receptor, which is expressed on several different cells within the body, including pulmonary epithelial cells, renal ductal cells, cardiomyocytes, as well as vascular endothelial cells. So that's kind of where it can wreak its havoc and where it can enter into cells and further on the disease. The life cycle of SARS-CoV-2 is depicted here. I won't go into extreme depth, but entry occurs, as I mentioned, with the spike glycoprotein interaction with the ACE2 receptor. It enters into an endosome, which drops the pH and then promotes the uncoating and release of the nucleocapsid into the cytoplasm. The positive sense RNA genome is then translated to polyproteins and lysed for replication. And the complementary strand is translated to viral proteins, which are then synthesized by endoplasmic reticulum to be used for assembly for new viruses. And the newly created particle then leaves via exocytosis and a final maturation stage where it then progresses on to infect other cells within the body. This slide here will help depict how COVID-19 impacts cardiovascular health. The virus enters the body, as we just talked about, and it can cause direct myocarditis or heart inflammation. And presence of the virus itself initiates the immune response, increasing macrophages and T cells, the inflammatory response, also a cytokine storm with increased levels of interleukin-6 and tumor necrosis factor alpha, which can lead to myocarditis itself and can also cause endothelial dysfunction, plaque instability, and it can also promote hypercoagulability or thrombosis within the vessels, and which can lead to acute coronary syndromes, as well as so myocarditis can also lead to heart failure and eventual possible death as well. And if we circle back here, the lung injury itself and the cytokine storm can cause lung injury, and along with thrombosis and potential PE can cause hypoxia. And then if we circle all the way back, the ACE2 receptor downregulates, increasing the amount of angiotensin 2, decreasing the amount of converting angiotensin 1 through 7, causing vasoconstriction of the vessels, which then can lead to increased pulmonary vascular resistance. And again, it can promote new symptoms or exacerbated symptoms of heart failure and can obviously lead to death as well. As far as symptoms and abnormalities that we might notice for a patient who's presenting with COVID-19 and cardiac-related symptoms, they might have palpitations that might be significant for arrhythmias. They could have some chest pain. They might also be hypertensive or hypotensive, depending on the severity or stage of the disease. Can also lead to new or exacerbate existing heart failure, as I just talked about, and that can present with typical heart failure type symptoms such as lower extremity edema, dyspnea or shortness of breath, and fatigue. And we might also notice some laboratory abnormalities, imaging abnormalities, such as elevated troponin, as well as B-type natriuretic peptide or BNP. And we might also notice electrocardiogram or EKG abnormality, signifying a potential arrhythmia. And then finally, we'll talk a little bit more in depth about cardiac imaging findings that might be significant as well. And that leads us to our first question via poll everywhere. So I pulled that up here. So it's a select all that apply question. What cardiovascular manifestations can occur as a result of COVID-19 infection? So we have myocarditis, heart failure, arrhythmia, and myocardial infarction. And then as a reminder, it is a select all that apply question, and I'll give you a few seconds to respond here. So we have 59 people in here and we got 43 responses already. So I'll give you a few more seconds here. We're at 59, we're at 60. Okay, so some other people might be listening in here, but 65, 70, I guess might be totaling all the responses. Sorry, this is first time with 60 people listening in. So seeing that we have 68 responses, let's see. So most people, yeah, correctly answered all that apply. So it says 28%, but it should be 100% for all. COVID-19 has the ability to cause all of these. So we'll talk about each one a little bit in depth. And we can talk a little bit more about that in the slides to come. As for, oh, I meant to hit the next button. All right, so a question for technicians. Which of the following symptoms of a COVID-19 infection is most likely related to cardiovascular abnormalities? Shortness of breath, cough, fever, or bilateral lower extremity edema? And again, I'll give you some time to respond here. So we're kind of bouncing between 12 and 13 responses. So I'll go ahead and showcase the answer here. So we do have shortness of breath and bilateral lower extremity edema tied for the lead. So the answer here is actually going to be bilateral lower extremity edema. And that's, as I mentioned, the symptoms associated that might lead to newer existing heart failure exacerbations, where the heart is not able to pump as well, and the fluid kind of gets backed up into the interstitial spaces, and that's when you have this bilateral lower extremity edema. The patient might also have shortness of breath, but we might possibly associate that more with the respiratory type illness that someone's having. So the best response here, the most likely response, would be bilateral lower extremity edema. As for cough, that's again more associated with respiratory type of illness associated with COVID, and then fever is more of that globalized one, but nobody answered that, so we're on the right track. And we will circle back to the presentation here. Click through a few slides. And we'll start talking about COVID-19 and myocarditis. So myocarditis itself is inflammation of the heart muscle or the myocardium. And as just mentioned, it may reduce the heart's ability to pump well. And it may also elicit arrhythmias. And typically, outside of COVID-19, this comes from an infectious source. In this case, COVID-19. It can also come from other types of bacteria or viruses. Also, toxic substances, as well as autoimmune disorders, can cause myocarditis. But in this case, we're specifically talking about COVID-19. The presentation can be asymptomatic, and basically what that means is that there might be imaging studies done that highlight inflammation within the tissue, and the patient doesn't have any symptoms currently. However, they can have chest pain, dyspnea, or shortness of breath, as well as fatigue and possible arrhythmia. And these type of symptoms and abnormalities associated with inflammation can cause left ventricular remodeling, as well as dilated cardiomyopathy, which can lead to heart failure, new onset or exacerbations of existing heart failure, which is important to note the severity of that type of illness. As far as diagnostics, endomyocardial biopsy, or EMB, is considered to be the gold standard. And what that means is it's invasive procedure where they take a biopsy of the actual heart tissue. Under histological slides, they see any sort of dense inflammatory cell infiltrate with neutrophilic predominance that kind of showcased here. This isn't specifically COVID-19, but this is what you would see on a histological slide. Whereas other methods here, like EKG, typically might be abnormal, but it's not specific or sensitive enough to say that the patient has myocarditis. Echocardiography, or an echo, is useful to exclude myocarditis. But it does not identify specifics of myocarditis. So if we don't see the inflammation that's associated, we might rule it out. But if seeing inflammation does not specifically say that person has myocarditis, as far as cardiac MRI or CMR, it helps us to identify myocardial edema, hyperemia, or excess blood in the vessels, as well as capillary leakage and fibrosis and necrosis of the tissue. But it does not showcase that dense infiltrative portion of endomyocardial biopsy that we would see on histological evidence. So, but oftentimes there's only a few documented cases of endomyocardial biopsy confirmed myocarditis in COVID-19, and that's most likely associated because it's an invasive procedure. It doesn't really change your management at all, knowing that they have myocarditis, and its cardiac MRI kind of has become one of the more predominant ways that we identify this type of inflammation. But again, the gold standard is EMB. We might also notice laboratory value elevations. Again, do not confirm the diagnosis, but these inflammatory markers like erythrocyte sedimentation rate, a C-reactive protein, as well as cardiac enzymes being elevated might help us lead in the direction of a diagnosis of myocarditis, but not definitively unless you did an actual EMB. As far as COVID-19, myocarditis in COVID-19, the CDC released information earlier this year saying that patients with COVID-19 are 16 times more likely to develop myocarditis than the general population. And that was 9 per 100,000 in the general population versus 150 per 100,000 in COVID-19 population. And this looked at patients in the US prior to COVID, prior to 2020, and then after COVID happened. So a significant increase in the risk of myocarditis. And in a prospective cohort study of about 100 patients with COVID-19, 60% of them had ongoing myocardial inflammation after cardiac MRI at an average of 71 days, which highlights the fact that this can be a long-standing issue, in this case over 2 months of that cardiac inflammation happening. So it can certainly impact the patient beyond just their acute illness. So it's important to assess this appropriately. As far as management of myocarditis in COVID-19, in large part, we're going to do general supportive care. So typically in myocarditis, we can use glucocorticoids, colchicine, potentially, and as well as NSAIDs. There's no definitive information currently treating myocarditis in COVID-19, but these therapies are oftentimes started, whether purposefully myocarditis or in case of glucocorticoids being used in respiratory type symptoms like the recovery trial, they are initiated. But in general, we want to treat the underlying infection. So we're going to again use medications like dexamethasone or remdesivir, and we'll talk about other medications we can utilize. We want to make sure that their infection is being properly treated. And if the patient's progressing to heart failure, we want to ensure the patient has access to guideline-directed medical therapy, including ACE inhibitors or ARBs, as well as diuretics, aldosterone antagonists, and beta blockers. And if a patient's progressing to a cardiogenic shock stage, we have the ability to use inotropes, vasopressors, mechanical circulatory support devices such as Impellas, as well as extracorporeal membrane oxygenation or ECMO. So there's no real deviation from current way we treat myocarditis, but it's again important that we address the infection to try and give some relief to the heart and the lungs in this case. There's been a lot of conversation about vaccination and whether or not there's a risk of myocarditis associated with them. So there's a study released with over 2.5 million patients in the Israeli healthcare system who had at least one dose of the Pfizer vaccine, and they showcased here the risk of myocarditis with the Pfizer vaccine was 2.13 per 100,000 as compared to the general population of 9 per 100,000, and with COVID 150 per 100,000. This was a shorter time frame. It was also the U.S. population being compared to Israel, and in general, 1 to 10 out of 100,000 patients in the general population, depending on what year, can have myocarditis, and then in the vaccination population, it's anywhere from 0.3 to 5. So these are specific numbers for this trial, but in general, your risk is highest with COVID-19 as opposed to general population or vaccination. And in a study of over 38 million people who were 1 to 28 days after their second vaccination or who were COVID-19 positive, they looked at incident risk ratios, which means that they looked at the incidence of myocarditis before COVID and looked at it after COVID infection or after vaccination, the risk associated with it. So for Pfizer, it was 1.30, not statistically significant, whereas for the Moderna vaccine, it was 9.84 statistically significant, and compared to infection was 9.76, also statistically significant. It's important to note that in large part, this was the myocarditis associated with vaccination is seen in a younger population, 16 to 29, and more specifically in a male population. So if there's patients who are resistant to get the vaccine because of potential symptoms like myocarditis, it might be a good idea to guide them in the direction of the Pfizer vaccine, especially if they're concerned, again, about that myocarditis picture. Now we'll talk about COVID-19 and heart failure. Heart failure, as a small background, it's functional or structural heart disorder and impaired ventricular filling or ejection. We often classify it as HFrEF, or reduced ejection fraction, meaning that's less than 40%, or HFpEF, preserved ejection fraction, and that's greater than 50%. Oftentimes, patients will have symptoms such as shortness of breath or dyspnea, weight gain, which can also be associated with edema or volume overload, and swelling in the extremities, as well as fatigue, potential chest pain, as well as nausea. So as far as the mechanism of COVID-19 in heart failure, we talked about it a little bit before with that one image, but on a smaller scale, we have the cytokine storm, which creates an inflammatory response, as well as elevated pulmonary pressure. Because of the hypoxia going on, elevated pulmonary pressure pressure, excuse me, and in some cases a pulmonary embolism that might be causing that as well as increased metabolic demand as the body itself is fighting the infection. We can also have ischemia and arrhythmia that we'll talk about a little later on that might be causing this type of issue, the cardiac depression, cardiac overwork, which can lead to new onset heart failure, as well as, again, acute decompensated existing heart failure. Pre-existing heart failure itself is an independent predictor of in-hospital death for patients who have COVID-19. There's a study of over 9,000 patients, 15.6 of patients who had heart failure passed away versus 5.6 of those who did not have heart failure. So this just speaks to the volumes to the fact that a patient with existing heart failure is going to be much at higher risk of dying within the hospital. And oftentimes that's because the person likely has lived a longer life. Their heart's kind of already been through stages leading to heart failure. And then they have a reduced immunity to fight the infection. They are a little bit more frail, and they don't have the hemodynamic reserve to cope with this severe infection. So we want to make sure we're appropriately addressing these patients and their needs. And for new heart failure, there's several different ones several different etiologies leading to new onset heart failure. We talked about myocarditis a little bit, but we also have Takotsubo or stress cardiomyopathy, which is a reversible cardiac dysfunction characterized by this ballooning of the ventricle or opening of the ventricle. And typically it's in the setting of extreme physical or emotional stress. This is when this happens. You can consider COVID being obviously extreme physical stress that the body's enduring, but also emotional stress. The patient might be not able to see family, not able to predict what this illness is going to do to them. So this situation can happen, and sometimes it doesn't exactly reverse totally. So the patient can have these longer type symptoms, and in general, there's a higher mortality associated with Takotsubo cardiomyopathy in patients with COVID-19 versus those that don't have it. And then typical other etiologies that patients might have with COVID-19 would be atrial fibrillation and myocardial infarction, which we'll talk about a little later on. As far as management of heart failure in COVID-19, guideline-directed medical therapy can be continued. There was some concerns early on in the pandemic that ACE inhibitors and ARBs were related to, because of the ACE2 receptor, there was concerns about either starting them or continuing them. And that thought was that there was upregulation of ACE2 receptors with those types of medications, but there's no evidence to suggest there's any detrimental effects of starting or continuing someone's ACE inhibitor or ARB. So those should be appropriately used in patients that qualify. We want to, in typical heart failure, we're going to have judicious fluid management. The same can be said in patients with COVID-19. We want to make sure that we're not overwhelming them and worsening any types of symptoms they're having or overwhelming the heart. And then for hemodynamic instability, we have the ability again to use inotropes, vasopressors, mechanical circulatory support devices, as well as ECMO. And again, the most important part here is that we're managing the underlying pulmonary disease to try and give relief to the heart and give more benefit to the possibility that they can revert back to normal cardiac function that they were having before their illness. COVID-19 and arrhythmia here. So we'll talk about several different types of abnormalities that can happen that can lead to arrhythmia. Specifically, inflammatory cytokines can cause a sympathetic overactivation that can lead to arrhythmia. And I should mention here, we have a action potential over cardiac myocyte. Talks about depolarization with the voltage-gated sodium channels, as well as initial repolarization, the plateau phase, and the repolarization, all typically associated with these voltage-gated ion channels. So interleukin-6 and tumor necrosis factor alpha can impact the cardiac potassium and calcium channels, which can pitch certain portions of this wave, again, eliciting potential arrhythmia. Hypoxia can modify L-type calcium channels, which you see on the plateau phase here, and that can kind of pitch the action potential and potentially cause arrhythmia. And COVID-19 itself can also lead to anaerobic metabolism, which reduces intracellular pH, and it can impact action potential duration. So another possibility of causing arrhythmia. And we talked about myocarditis, remodeling the tissue, ischemia potential within myocarditis, as well as gap junction, which is important for impulse conduction, and ion channel dysfunction, which can all lead to arrhythmia, and as well as post-inflammatory response within the tissue can cause fibrosis and scarring, which can have re-entrant arrhythmias as a potential there. And then as a more global side effect with kidney and GI dysfunction that might be going on, it can lead to electrolyte abnormalities. And as we see here, sodium, calcium, potassium, if those are impacted, it can impact the potential for arrhythmia. And again, we'll talk about medications during the last third of the presentation. So we'll talk about what we need to do as far as monitoring first. You want to obtain a baseline EKG to assess someone's QTC, and as well before you start any QTC prolonging drugs. This is important because if someone's QTC is prolonged, they're at an increased risk of arrhythmias. So telemetry monitoring should be considered in patients with documented cardiac arrhythmias, those who might have suspected myocardial ischemia or other indications, such as starting a QTC prolonging drug. In general, the 99th percentile of QTC value, so that kind of the higher limit that we're going to look at, is going to be for males 470 milliseconds and for females 480 milliseconds. And it's kind of within a clinical judgment what you're comfortable with. Again, these are the higher side of things. Some people might say 500 is their limit. It all depends on your clinical judgment, your clinical expertise. But if you're seeing levels this high and starting a QTC prolonging drug, it's especially important to have a conversation and be judicious in doing so. As far as arrhythmia incidence within COVID-19, we have sinus tachycardia, which is quite often associated with infection in general, so it's not often pathologic. Same could be said for sinus bradycardia. It can be seen within COVID-19. Again, not often pathologic. It can also come from medications, and we'll talk about remdesivir a little later on. But as one of the more common pathologic arrhythmias, we have atrial fibrillation or atrial flutter, and that's one we'll talk about a little more in depth. The rest here can be are seen as the reported incidents, but not seen as common as, again, as bradycardia or atrial fibrillation. So atrial fibrillation itself, there's an increased risk when having infection of developing atrial fibrillation, but in COVID-19 itself, there was a 2021 meta-analysis of almost 22,000 patients who were hospitalized with COVID-19, and their prevalence of atrial fibrillation was 11%, as opposed to the general population being anywhere from 2.3 to 3.4%. Again, an infection is going to elicit more potential for arrhythmia and atrial fibrillation, but in this case, prevalence was 11%, which is an important thing to address and make sure that we're keeping an eye out for. There was also a 6-fold higher prevalence of atrial fibrillation, those with severe disease versus those with non-severe disease. And the mortality associated with atrial fibrillation was much higher in atrial fibrillation patients. It was the odds ratio of mortality, all-cause mortality, was 2.98 in patients with existing atrial fibrillation, and it was 2.32 in patients with new onset. So, excuse me, definitely an important thing to keep an eye on and make sure we're addressing appropriately. Excuse me. As far as bradycardia, there was a 2020 multi-center retrospective analysis of 1,000 patients with COVID-19. They looked at profound bradycardia being a heart rate less than 50, and absolute being a heart rate less than 60. And the incidence of that was 13 and 25% respectively. And the mortality rate was 25% in the profound group and 18% in the absolute group, as compared to the whole population was 18.7. So higher within the profound group and a little bit lower in the absolute group. But in general, patients who had bradycardia, patients who had a heart rate less than 60 were about 7 times more likely to die than those who had a heart rate greater than 60. And this just speaks to the heart's ability to pump and perfuse the vital organs we have in our body. So patient, if they're bradycardic persistently, it's important that we try to address that, as they have an increased risk of dying, as it says here, 7 times more likely. So what can we do for these patients? Medical management, again, it's very standard. as opposed to a non-COVID patient. But for rate control specifically, beta blockers can be a concern because of the potentiation of breathing concerns with the beta blockade. So as an alternative medication, we can use non-dihydropyridine calcium channel blockers such as diltiazem. Specifically for a bradyarrhythmia, we want to ensure the patient's not on any sort of AV nodal blocking medications or any rate control medications like listed here. And then you can consider permissive hyperthermia. Oftentimes when a patient has infection, they're going to have a higher heart rate. So using medications like antipyretics such as acetaminophen can blunt that hyperthermic response. So removing those medications can help with that. But outside of that potential, there's no specific guidance outside of the standard of care that we would do in a non-COVID patient who's having bradyarrhythmia. If a patient is developing QTC or they have a QTC prolongation before starting a medication, we would consider not starting it. And if they develop it, we would consider discontinuing the therapy. It's kind of a risk versus benefit. But in this case, most often we probably want to avoid any kind of QTC prolongation due to the arrhythmia potential. Finally, here we'll talk about COVID-19 and acute coronary syndrome. So acute coronary syndrome is the suspicion of an ST elevated myocardial infarction, or what we commonly call as a STEMI, and versus a non-STEMI or non-ST elevated myocardial infarction. And we see the normal morphology of a heart wave here. And this is the ST elevation. So we sometimes call them graveyards or gravestones, excuse me. So that's that rounding of the ST here can be very pathologic, and we want to address them appropriately very quickly. So a myocardial infarction in general is diagnosed with cardiac troponins above the 99th percentile, as well as one of the following being symptoms, EKG changes such as ST elevation or depression, as well as pathological Q waves. And these are typically what result from somebody having a prior myocardial infarction. So this might be a second or subsequent event. And then if there's any sort of imaging with a new loss of viable myocardium or wall motion abnormality, the saying kind of goes, time is tissue. So if we're seeing that there's not proper perfusion or there's a wall motion abnormality, the tissue could be not appropriately working and not being oxygenated appropriately. We have type 1 versus type 2 myocardial infarction. Type 1 is what we commonly kind of associate with a heart attack or an MI, and this is that rupture of some sort of atherothrombotic plaque that causes a blockage, and we see that kind of here. There can also be type 2, which is more associated with COVID-19, and this comes from a mismatch in the oxygen supply and demand, typically associated with respiratory abnormalities that are going on. We're not oxygenating the blood appropriately. We're not able to get it back to the heart. Potential risk of poor oxygenation causing that type 2 myocardial infarction. And in general, myocardial infarction in COVID-19 can be a concern. There was a Danish study in 2021 with over 5,000 patients. 17 of them had their first ever MI. And this kind of harkens back to that incidence risk ratio, which is before COVID-19, as opposed to after COVID-19. So patients were at almost six times more likely to have their first MI with COVID-19 versus without. So definitely a serious condition and something we have to appropriately evaluate should a patient have symptoms or laboratory values. In a New York study, over almost 5,000 patients they evaluated acute and chronic myocardial injury, and they looked at chronic being somebody who had a elevation on their first assessment and subsequent assessment less than 20%, versus acute myocardial injury was normal on first assessment and then a subsequent elevation of more than 50%, or if it was elevated initially, a subsequent elevation of more than 20%. So again, kind of a chronic being existing and acute being happening after they present. So they looked at 6.8% of patients with chronic, 25% of patients with acute, and the all-cause mortality in general was just short of 25%. 13% of those patients without MRI, so much lower in a non-MI population versus 43% with a chronic MI and 47% with somebody with an acute MI. So we have to appropriately address these patients up front to make sure that we're trying to prevent this kind of serious mortality associated with MI. And how we can do that, again, time is tissue. So in general, outside of COVID-19, with MIs, for every 10-minute delay in percutaneous coronary intervention, or PCI, which we can see here is the stent being placed within the cardiac vessel. For every 10-minute delay, there's an additional 3.31 deaths per 100 patients. So that speaks to how we need to really quickly address that patient should we have the ability to do so. So oftentimes we'll use fibrinolysis if a patient cannot have access to the cath lab, but if we have that ability, we shouldn't be delaying that. There was some thought in the beginning of the pandemic that we'd be spreading the disease because the patient might be infecting the people who are performing this, but at this point in time, we have vaccinations, we have proper protective equipment. So, masking the patient, masking everybody in the room, and wearing proper masks is going to reduce it significantly and give the benefit of potential life to the patient. So we're making that risk-benefit analysis, but in most cases, PCI is going to be an important factor, and we don't want to get them there as soon as possible. Excuse me. So typical pharmacological treatment after stenting should still be started and or continued. So therapeutic anticoagulation, aspirin or a PTY12 inhibitor for that DAP therapy, as well as beta blockers, statins, and ACE inhibitors or ARBs. So we're going to kind of continue in that direction. But again, we don't want to delay any of that because of their illness. We have our second set of questions here. So I'll bump over to the questions. So the second pharmacist question: what method is considered the gold standard for evaluating myocarditis? And it should more specifically say diagnosing myocarditis. We have endomyocardial biopsy, or EMB, electrocardiogram, EKG, echocardiogram, or echo, and finally cardiac MRI. All right. Responses seem to be slowing down a little bit, so we'll take a look here. So vast majority of people answered correctly here. It's going to be endomyocardial biopsy. Again, that histological evidence of the infiltrative neutrophils is going to be the highest, the gold standard. An EKG might be abnormal, but you can't definitively say that would be the gold standard in diagnosing somebody. An echocardiography, or echo, can showcase that inflammation and help rule out myocarditis more specifically, but again, not the gold standard, not diagnostic. And cardiac MRI, again, is what we most commonly use, but it does not showcase the histological evidence, although we can use it to see that myocardial edema, the fibrosis, the necrosis of the tissue, that inflammation that we'd be concerned about. And again, most of the confirmed cases of COVID-19 myocarditis come from cardiac MRI. There are very few with EMB, and that's just because of the invasiveness and the lack of change in treatment that you would do. For technicians, we have one second question here, which is: which of the following can be directly attributed to a COVID-19 infection? Lung cancer, glaucoma, urinary tract infection, or myocarditis? Looks like we have a pretty similar number of responses to our first question, so looks like most people might have answered. 100%. We nailed this one. So lung cancer, a patient might have lung cancer and develop COVID-19 infection, but no evidence to showcase that it causes lung cancer. Again, same with glaucoma. They may have glaucoma and have COVID-19, but does not cause glaucoma. And finally, for a urinary tract infection, similar story, does not cause a urinary tract infection. A patient may have a urinary tract infection along with COVID, but myocarditis specifically can be caused by COVID-19. So great job on this question. We'll bump back to the presentation. Finally, we'll talk about cardiovascular implications of COVID-19 medications. First one being dexamethasone or Decadron. And you might be surprised to find out that this is currently not approved for COVID-19, but it's the mainstay of treatment. They haven't done any approval. The recovery trial showcased the benefit, so it's commonly used. It's kind of one of the first medications used in someone who's requiring supplemental oxygen or mechanical ventilation. It works as a glucocorticoid to suppress neutrophil migration and lymphocyte proliferation. So it works as an anti-inflammatory to help the lungs work a little better. And again, it's used in that supplemental oxygen mechanical ventilation picture. Typically, it's dosed 6 milligrams IV or PO for 10 days or till discharge. There are some different types of dosing. Sometimes a trial was done for 20 milligrams for 5 days and then 10 milligrams for 5 days. But in general, IV or PO or until discharge. The potential cardiac impact here, dexamethasone can cause hypertension, dyslipidemia, or abnormal lipid panel, and then it can cause fluid retention as well as electrolyte abnormalities like increase in sodium or decrease in potassium. So we're monitoring blood pressure, potentially, again, monitoring that lipid panel, any sort of edema or worsening chest congestion potential, and then electrolytes on daily labs are also something we want to keep an eye on, make sure we're not potentially causing any sort of arrhythmia. As far as remdesivir, we've talked about it a couple times, or this is Veklury. This one is fully FDA approved in COVID-19. It works as a nucleotide analog, preventing the viral RNA synthesis by resembling a natural ATP. And that's kind of where the potential risk of a bradyarrhythmia comes from, or bradycardia, with the adenosine slowing the AV nodal conduction and causing a bradyarrhythmia. And that should circle back. So it used in patients with COVID-19 within 10 days of symptom onset. Again, 200 milligram IV infusion on day 1, followed by 100 milligrams IV infusion daily for 4 total days or until their discharge. And now we can talk about the bradyarrhythmia. So typically, QTc prolongation / bradyarrhythmia, it typically resolves after the completion of therapy or with the discontinuation of the therapy. So if a patient is developing bradycardia, we want to be judicious in potentially stopping therapy if we think that that is prudent. So having that conversation with providers is important, and make sure we keep an eye on it, as well as T-wave abnormalities and potential hypotension with the medication, specifically during the administration phase. Baricitinib, or Olumiant, is approved via emergency use authorization, or EUA. This is a JAK inhibitor, Janus kinase, and it helps to modulate the inflammatory response, specifically with interleukin-6. This is used in patients who have high flow oxygen, high flow nasal cannula oxygen needs, or non-invasive ventilation, as well as an inflammatory marker above the upper limit of normal, and those are C-reactive protein, a D-dimer, an LDH, or a ferritin. So that's kind of the qualification to use baricitinib. It is dosed by mouth. This is done for 14 days or until discharge, and there is a dose adjustment for people who have kidney dysfunction, specifically based on their GFR. And this medication can cause, DVTs and PEs, but there is no evidence to suggest at this point that can cause arrhythmias. Tocilizumab, or Actemra. This one is again approved with an emergency use authorization, and it's a monoclonal antibody that binds to the interleukin receptor, preventing the inflammatory action associated with COVID. This one is used for high flow nasal cannula and non-invasive or invasive ventilation, and they typically, they have to have a C-reactive protein above 7.5 milligrams per deciliter to be qualified for this therapy, and that's an inflammatory marker. And then the dosing is typically a one-time infusion, 8 milligrams per kilogram up to 100 kilograms. So the patient's 120 kilograms, for instance, the max dose is still going to be 800 milligrams. And this one has the potential to cause hypertension as well as thrombocytopenia. That can cause DVT and infections. This one has kind of a cardiac protective measure that it actually shortens the QTc, but we want to make sure we're keeping an eye on any potential laboratory abnormalities with their thrombocytopenia, as well as any potential symptoms of a DVT they might develop after initiating therapy. Sotrovimab, or Xevudy, is approved with the emergency use authorization. And this is an immunoglobulin G1 monoclonal antibody, and it binds to the spike protein receptor domain and inhibits kind of an undefined step in the attachment process, preventing COVID from actually getting into the cells. This is used in high-risk patients, high-risk positive COVID-19 patients who are not admitted and not currently requiring mechanical support, typically within 10 days of symptom onset. This is a one-time IV infusion, and currently there's no concerning cardiovascular effects. Molnupiravir, or Lagevrio, this is approved via an emergency use authorization. This increases a frequency of viral RNA mutations, and it acts as a substrate for the RNA polymerase. This one is used in mild to moderate severity COVID-19 in patients who are not hospitalized and within 5 days of symptom onset. This one has been talked about a little bit in the community with test to treat. So patients are going to use this as a by mouth medication. It's 4 200 milligram capsules every 12 hours for 5 total days. And currently there's no concerning cardiovascular impacts or drug interactions to be concerned with it at this time. As opposed to Paxlovid, which has had some recent controversy, so to speak, within the community, the medical community specifically. So it's kind of the test to treat. So pharmacists may be dispensing this medication to patients. So we'll talk about the drug-drug interactions in a second, but it is approved via emergency use authorization, and it acts as a nucleotide analog, which prevents RNA synthesis by resembling that natural ATP substrate. And again, similar to Molnupiravir, mild to moderate COVID, non-hospitalized, 5 days of symptom onset. It's going to be 3 total pills, 2 of which are the nirmatrelvir, 300 milligrams total, and then ritonavir, 100 milligrams. And this is all 3 taken together twice daily for 5 days. And again, the drug-drug interactions is the important part here, as well as potential edema and hypotension. As far as the drug-drug interactions, that's the part of the ritonavir, which is the booster to the nirmatrelvir, and that's the cytochrome P450 PGP inhibitor. So there's a lot of medications, specifically cardiovascular medications, that might be impacted. So the NIH produced a list here of common medications that might be impacted, and those I listed some of the cardiovascular ones here, being amiodarone, clopidogrel, dofetilide, ivabradine, rivaroxaban, ticagrelor, or again, many others. So if a patient's already on one of these medications, it might be prudent to try Paxlovid or Molnupiravir instead, Lagevrio or Molnupiravir instead. And then if the patient's taking any sort of statin or tacrolimus, opiate pain medications, and we have the ability to hold those medications, we can certainly do Paxlovid. But if the controversies associated that maybe pharmacists wouldn't be the best person to evaluate whether there's a drug-drug interaction, but I think we could all argue that we do that in our day-to-day practice, and that's one of the benefits that we provide to our patients is that we're evaluating this. So making sure if we're dispensing these to patients, to properly assess what medications they might be using at home, trying to do kind of a med rec in that sense to make sure we're not putting them at risk of any sort of potential abnormality within the cardiovascular system that we want to be concerned with. So specifically for those 2. As far as casirivimab and endevimab, as well as bamlanivimab and etesevimab, these 2 were previously used before the Omicron variant, but because they don't have action, because of the spike protein mutations that have been going on with the virus, they're no longer used in the United States, so we won't really talk about those ones at all. And this kind of kicks off the not approved medications for COVID-19. Some of them still might be used for COVID-19, or a patient might have, for instance, a CAP or a community-acquired pneumonia picture where they might be using a medication like azithromycin. So we can talk about the medication, but again, these are not approved for COVID-19. and the NIH recommends against it. It's a macrolide antibiotic with immunomodulatory activity, decreases inflammatory cytokines and neutrophil activation, specifically prolongs the QTC interval. So we want to make sure we have a baseline if a patient's on this and monitor appropriately. Same can be said for hydroxychloroquine or Plaquenil, not approved for COVID-19. The NIH recommends against its use. Again, the studies do not showcase benefit, so we're not going to be using these. Again, hydroxychloroquine can prolong the QTC and also has drug-drug interactions. Same can be said for chloroquine, what kind of a sister medication, not approved for COVID-19 and we're recommending against its use. But again, the QTC prolongation and drug-drug interactions can be a concern. So we want to make sure if a patient's on one of these medications that we're monitoring these appropriately and making sure there's no drug-drug interactions. Ivermectin, which has been talked about in the community quite a bit, not approved for COVID-19 treatment. There's not sufficient evidence to suggest for or against it, but currently we're not recommending to use it. It's not approved for it, so we want to avoid it. It's an antiparasitic that works for onchorosiasis or strongyloidiasis, and it's thought to inhibit transport proteins that interfere with the attachment. But again, not recommended, but it can cause tachycardia, edema, orthostatic hypotension, and some drug-drug interactions. So we're keeping an eye on a patient's cardiovascular abnormalities and making sure that we're not having any concerns there. Nitazoxanide or Alinea is not approved for treatment of COVID-19. The NIH recommends against its use. It's an antiparasitic, no concerning cardiovascular impact, but we want to avoid that one. Colchicine or Colchris is an anti-inflammatory, sometimes used in gout or pericarditis. We want to avoid using this because it's not approved in COVID-19, and the NIH recommends against its use. A patient might be on it if they're treating myocarditis, which has not been approved, but again, it's not approved in COVID-19 either. So just keep an eye on that, especially for the drug-drug interactions, as it is a major CYP3A4 and PGP substrate. Anakinra or Kineret is not approved for treatment in COVID-19, not sufficient evidence for or against it. It helps with anti-inflammatory, but it has the potential to cause infection as well as cause a pulmonary embolism. So keeping an eye on any sort of breathing abnormalities or infection potential there. Canakinumab or Ilaris, not approved for COVID-19, and we're not currently recommending being used. It's a monoclonal antibody that works on suppresses inflammatory effects, no concerning cardiovascular impact, but again, not approved. And cetuximab or Sylvant, not approved for COVID-19 and recommending against its use. It's again, works on the anti-inflammatory signaling, and it can also cause edema, hypotension, which hopefully we wouldn't see because it's not approved for COVID-19 and not being recommended. We have our final question. For pharmacists, which of the following medications should we be especially concerned with regarding drug-drug interactions that may elicit cardiovascular adverse effects? Molnupiravir or Lagevrio, baricitinib or Olumiant, ritonavir, nirmatrelvir, Paxlovid, or sotrovimab Zevudy. Give you a few seconds to respond here. I know I'm close to my time. Responses are slowing down a little bit, so in the interest of time, and we nailed it here, so 93% and 100%. So the ritonavir portion of that has the drug-drug interactions, and especially if we're going to be dispensing in the community, you want to make sure we can properly have a conversation with the patient and make sure that there's no concerning drug-drug interactions. Again, using a medication like molnupiravir might be the better choice as it does not have the drug-drug interactions associated with it. And then baricitinib, again, no drug-drug interactions there to be concerned with, and sotrovimab as well, none there. So ritonavir, nirmatrelvir, or the Paxlovid is one we're concerned about. Final one for technicians: which medication is given as an intravenous or IV infusion rather than by mouth? We have molnupiravir or Lagevrio, remdesivir or Veklury, baricitinib, Olumiant, and finally ritonavir, nirmatrelvir, or the Paxlovid that we just talked about. Have some responses rolling in here. Boom, correct. So remdesivir is the IV infusion, typically 200 milligrams on day one, followed by 100 milligrams IV for 4 days total or discharge. Whereas molnupiravir or baricitinib and the ritonavir and the nirmatrelvir is all by mouth. So you guys did really well with that one. And I'm going to go back to potentially my presentation. There we go. Click through, and that completes my presentation. So again, thank you for joining me as we talked about the impact of COVID-19 and its treatments on cardiovascular health. I hope you were able to glean some benefits for your practice, and I open the floor if we have any time for a couple questions should you have them. So please feel free to put them in the chat or unmute your mic.